Subsequently, she came back down to this area in 2010 and has joined Johns Hopkins and is the director for the vascular medicine at Johns Hopkins. She practiced vascular medicine locally at Frederick, Maryland. Maya, thanks for coming. I'll turn over the talk to you.
So thank you so much for the opportunity to speak today. I'll be talking about the diagnosis and medical management of peripheral artery disease, which is a particular passion of mine. I've been doing this for many years now. I do not have any disclosures. So I'm going to start with some definitions because PAD, people use the term in different ways. It can have a very broad definition where people talk about it as any atherosclerotic disease in the non-coronary circulation. So that would include carotid disease, renal, aorta, et cetera. And then there's a more focused definition, which is lower extremity PAD. Referring to obstruction of the aorta and arteries to the lower extremities. So this is actually the focus of my talk today, lower extremity PAD, and that's what I'm referring to when I use the term PAD. Obviously, there are other non-atherosclerotic arterial diseases, but I'm not going to be covering those in this talk. So when you look at the prevalence of PAD, it really depends. The prevalence you report depends on the population you're testing for it. So if you look at the general population, healthy adults above the age of 40 here in NHANES, the prevalence of PAD in that population is relatively low, 4.3%. But as you start to screen higher risk patients, older age, or patients with risk factors, you can find PAD prevalences that are quite high, up to 29%, 30% in these high-risk patient populations. And in fact, we have multiple studies that have shown that PAD really is a disease of aging. It is relatively uncommon below the age of 55, but once you get to age 65 or so, you really start to see this exponential increase in the prevalence of PAD, especially in the 80s decade, a significant increase in prevalence in that age group. So these are the odds ratios, age and gender adjusted odds ratios for risk factors for PAD. This is based on data from NHANES. And what you can see here is that smoking and diabetes are actually the two strongest risk factors for PAD. You also have hypertension, hyperlipidemia, similar to some of the risk factors for coronary artery disease. It's important to remember that the atherosclerotic pathophysiology of that underlies PAD doesn't really occur in a vacuum. PAD is part of a systemic disease process that can affect multiple vascular territories, and notably coronary arteries and cerebral arteries. So this was shown here in this overlap in the REACH registry. This was a very large international registry, over 70,000 patients in 44 different countries, included over 7,000 patients with symptomatic PAD. And what they showed was that 63% of PAD patients had symptomatic disease in at least one of their vascular beds. So it's symptomatic CAD with recent MI or symptomatic cerebrovascular disease with a stroke. And multiple studies have indeed shown this, that PAD patients are at significantly increased risk of cardiovascular events, including stroke, MI, and cardiovascular death, six-fold greater risk of death from cardiovascular disease in PAD patients. And in fact, the REACH registry showed the outcome events in the PAD patients, and I'll draw your attention to the 3-year follow-up outcomes. You can see that the PAD patients actually had the highest event rate of all the patients, 40% event rate in PAD patients compared to about 30% in CAD patients and 28% in cerebrovascular disease patients. And that translates into what you see in the natural history of PAD. This is looking at 5-year outcomes from both the limb perspective and cardiovascular perspective. And I'll draw your attention to the 5-year mortality, up to 30% in patients with PAD, which is really a terrible prognosis for these patients. And majority of causes of death are cardiovascular causes. It is important also to look at the limb morbidity. While the majority of patients with PAD will experience stabilization in their claudication symptoms, up to 20% will have worsening claudication, which negatively impacts on their mobility and quality of life. And up to 2% actually proceed to critical limb ischemia, which can have devastating consequences in terms of gangrene, amputation, et cetera. So I'd like to present a case as one of my patients, which I feel like will illustrate some of the topics I want to cover today. So this was a 54-year-old gentleman who presented with bilateral thigh and calf fatigue with walking. He also described it as a weakness, and then at times would experience some thigh numbness, which would begin sooner when he started to walk. He did not have any pain at rest. The patient also reported low back pain that was worse with exertion and had a known diagnosis of spinal stenosis. Overall, he estimated his exercise tolerance to be about 10 blocks, which he states was significantly reduced in the last few years. The patient is a current smoker, a very heavy smoker. He has some hypertension for which he is prescribed hydrochlorothiazide and a hyperlipidemia for which he takes simvastatin 20 milligrams daily. His most recent LDL was 103, and notably the patient had no prior history of CAD or MI or history of stroke. On exam, he was noted to be hypertensive, and he had a right femoral bruit detected as well as diminished pedal pulses. So I think the questions to answer in this patient evaluation are, first, does this patient have peripheral artery disease? And we'll work that up. And then the second question is, if he does have it, how does this impact his prognosis and change his medical management? So I wanted to spend some time talking about intermittent claudication because most of us think of it as this very classic syndrome where the patients will develop calf cramping with walking a certain distance and relieved by rest. But it's actually a much more variable symptom complex than that, and can present really in a non-specific way. So the patient may actually report weakness in their legs or numbness or tiredness. And that's really a problem because a lot of these patients have other comorbidities like obesity, diabetes, neuropathy that can also present that way or affect the way that they present with their claudication. So that a lot of times makes it very difficult to detect which patient may actually have PAD based on their leg symptoms if they're not specific. And in fact, if you look at the clinical presentations of PAD in terms of leg symptoms, up to 50% are reported as being asymptomatic. Although I'll show you some data that shows that these asymptomatic patients actually do have some impairment in their function. So only 15% of PAD patients will present with this sort of classic claudication that I just talked about. And up to a third are going to present with more atypical leg pain, like this patient that I just presented to you. Mary McDermott out at Northwestern has done a lot of work, a lot of studying on this topic of asymptomatic PAD. This was one of the studies looking at patients in the women's health and aging studies, 328 of whom had documented PAD. Of those patients, 63% reported no leg symptoms at all, being asymptomatic. However, when she actually measured their lower extremity function, they found that these patients had slower walking velocities, poorer balance scores, and fewer blocks walked per week compared to comparable patients who did not have PAD. And this was after adjusting for traditional risk factors and comorbidities. So even though these patients reported being asymptomatic, they actually had documented objective impaired lower extremity function. She also did another study, which I thought was interesting. This was in patients with known moderate PAD, and asked all of them about their leg symptoms and categorized them in terms of their category of type of leg pain. And I want to draw your attention here to the patients who reported being always asymptomatic. These patients actually walked the fewest feet when she made them do a 6-minute walk test, an observed 6-minute walk test. So of all the patients with PAD who had some leg symptoms, the ones who said they had no leg pain at all were the ones who walked the least, were not able to walk as far. And I think the reason for that is that patients who have PAD almost subconsciously limit their activity because they don't want to bring on the leg pain or the leg discomfort. And so they end up walking less and less over time. And that can make it very difficult to detect that these PAD patients. So when you look at the physical exam with PAD, I just want to point out a few things. First is we always do bilateral brachial pressures in these patients because there's a high incidence of subclavian stenosis in this patient population, and that's a good way to screen for that. We're also doing a comprehensive pulse exam, looking for ulcers in a typical location, also looking for leg hair loss, which can be an early sign of PAD. And I put femoral bruit there because I think it's useful. It's easy to listen for. And if you hear of femoral bruit, that's very helpful because it significantly increases the likelihood that the patient has PAD. So going back to our patient, 54-year-old gentleman with multiple risk factors for PAD, including heavy tobacco use, is presenting with what I would characterize as atypical exertional leg pain. So it's not typical claudication. He also has spinal stenosis, which could be masking the typical claudication symptoms. On exam, he has certainly findings that could be suggestive of PAD, including a bruit and femoral bruit and diminished pedal pulses. So what's the next step in evaluating this patient? And this brings me to the ABI, which is the first-line test in the diagnosis of PAD, and probably the most important test we have available to detect PAD. It's defined as ankle systolic pressure divided by brachial systolic pressure, with an ABI of less than 0.9, essentially establishing the PAD diagnosis. The way you do the ABI is basically you're measuring the systolic pressure. You have to use a Doppler probe. It cannot be done with a stethoscope. And you're measuring the pressure at the ankle in two places, at the anterior tibial dorsalis pedis artery and at the posterior tibial. You take the higher of these ankle pressures and divide by the higher of the brachial pressures, and that's your ABI for that leg. And then you obviously repeat that for the other leg. So the ABI is also a great measure of lower extremity perfusion. It can give you a sense of how significant the patient's disease is. So you have different categories of ABI, 0.7 to 0.9 being mild, 0.4 to 0.7 moderate, and less than 0.4 is severe. Now, there are limitations to the ABI. It may actually be normal at rest in patients who have very proximal PAD. And then you can also have medial calcification in these patients' arteries, especially in chronic kidney disease patients and diabetics, which can really falsely elevate the ankle pressure. It's kind of like trying to take the blood pressure of a sink. And so then the ABI is rendered unreliable in that context. In the vascular lab, we also add non-invasive flow studies to the ABI to help us get a better understanding of the degree of PAD that the patient has. And I'll show you just briefly what we're doing in the vascular lab. But essentially, we are measuring ABIs at the ankle, but we also measure thigh pressures and calf pressures, which can help us localize the lesion. Is it more proximal? Is it more in the femoral popliteal segment? Or is it more distal? The other thing we look at is pulse volume recordings. These are measured using a method called plethysmography. And what we're doing is we wrap the blood pressure cuffs at the different levels in the legs and inflate them to about 60 millimeters of mercury of air. And as blood passes through that segment throughout the cardiac cycle, you're going to see a change in the pressure in the cuff that can be translated into this pulsatile waveform that's essentially a proxy for flow. So here you see normal waveforms with a nice upstroke in systole and a dicrotic notch in diastole. And then here you see mildly abnormal and progressively moderate and severely abnormal waveforms. So these are really good to give you a sense of the flow in the patient's legs, and they can be especially useful when the ABI is unreliable because of medial calcification. So if you go back, this is our patient that I presented. This was his flow study that was done in the vascular lab. And you can see by the PVR tracings that he has mildly reduced flow in his bilateral lower extremities, and his ABI also in the mild range, 0.84 on the right and 0.86 on the left. Now, we also do exercise ABI testing in the lab. I find it to be very useful, not just to assess the patient's functional ability, but to also differentiate claudication from other causes of leg pain, like in this patient's case, who also has spinal stenosis. So the goal is to put him on a treadmill at a certain pace. It depends on the patient, but the idea is to reproduce their leg symptoms and then to look for an ABI drop post-exercise to confirm the PAD diagnosis. So this is what we did with this patient. We brought him back and had him do an exercise ABI. And you can see here that he developed symptoms during his exercise. And at the end of the 5 minutes had dropped his ABI to 0.28 on the right and 0.35 on the left following exercise. So the answer to the first question is yes, indeed, this patient has peripheral artery disease. And I think we can reasonably say that it's contributing significantly to his exertional leg symptoms based on the exercise ABI. So now we move on to the next question is, how does this diagnosis impact his medical management? So as I showed you before with the REACH registry, we've learned that despite what we consider to be optimal medical therapy, symptomatic PAD patients actually doubled their cardiovascular event rates from year 1 to year 3. And they also had persistently elevated limb event rates, despite being treated with what we consider guideline-driven therapies. So this obviously can be discouraging when you look at this kind of data, and it makes you wonder are we missing a tool in the toolbox, or is there something we're not doing correctly in helping these patients reduce their risk? So I like to look at this kind of toolbox analogy for the in the goals of medical management of PAD, because there really are two main goals. The first one is to help the patient live longer, and then the second one is to help them feel better. So in speaking about the live longer aspect, there's two major aspects to that, and that's risk factor modification and antithrombotic therapy. So I'll start talking about risk factor modification first and the data behind that. So obviously smoking cessation is an important part of what we do. 80% of our patients are either current or former smokers. We know that the risk of death, MI, and amputation is higher if the patients keep smoking, and they're also at increased risk for early graft failure if they have bypass surgery. There are multiple agents available to help pharmacologically with smoking cessation in addition to behavioral modifications. I just wanted to touch a little bit on the EAGLES trial. This was a trial looking at varenicline, bupropion, and nicotine patch in over 8,000 smokers who had psychiatric, with and without psychiatric disorders. So this was a randomized double-blind study with the placebo arm and then an active control for nicotine patch and active arms varenicline and bupropion. So this is the results, and this is actually sort of a busy slide, but basically what the trial showed was that varenicline was more effective than all the other therapies in smoking abstinence, and bupropion and nicotine patch were also more effective than placebo. And then notably, there was no increase in neuropsychiatric adverse events attributable to either varenicline or bupropion, and that included in patients with underlying psychiatric disorders. Although I have to point out that those were patients with stable psychiatric disorders, not unstable. The other study looking at varenicline that I thought was interesting was for smokers who were not willing to quit quite yet, but were willing to cut down and attempt to quit within the next few months. And in those patients, they looked at giving them varenicline for a longer period of time and having them gradually reduce their smoking. And what they found was that varenicline significantly increased smoking cessation rates compared to placebo, not only at 24 weeks, but all the way out to 1 year. Notably, again, there was no difference in some of the more concerning adverse events that we might be worried about, depression, anxiety, or increase in suicidal ideation. So I'd like to shift gears now and talk about lipid therapy. This is a very important part of what we do in treating patients with PAD. So as I've shown you, patients with PAD are at even higher risk than patients with CAD in terms of their cardiovascular risk. And we have good data that statins reduce death, MI, and stroke in PAD patients. So what the first major study, or one of the major studies looking at that, was the heart protection study, which I'll show you here. This was looking at over 20,000 patients with CAD, PAD, or diabetes who are randomized to 40 milligrams of simvastatin versus placebo. And overall, you can see simvastatin reduced the risk of major vascular events by 24%. And that was regardless of what the patient's LDL was at baseline. This benefit was also preserved in the PAD subgroup that was included in the heart protection study. So despite this and other data, there's still, we're still finding that statins are underprescribed in PAD patients. So this was a study examining the frequency of statin prescription in PAD patients enrolled in primary care practices in VA, in the VA system. And what they found was that patients who had a diagnosis of PAD, 31% of them were not prescribed any statin at all. Only 29% were prescribed appropriate statin, and about 40% were being prescribed an inappropriate statin dose. So what do we consider an appropriate statin dose for PAD? So the guidelines recommend high intensity statin for these patients. And I'll show you how they define that a little bit. I think you'll remember that in 2013, the ACC/AHA guidelines tried to move away from specific LDL targets and instead said that we should be lowering LDL by more than 50% from baseline for our high-risk patients. I think in practice, LDL targets are still very much in use. The guideline update in 2018 sort of acknowledged that and said, for your high-risk patients, you can add other agents or change statin intensity if you haven't achieved an LDL goal of less than 70. And the question of statin intensity is very important. So a high intensity statin is basically defined as one that achieves a greater than 50% reduction in LDL from baseline. And you can see from this chart that really the only statins that come close to achieving that are atorvastatin 40 milligrams or higher and rosuvastatin 20 milligrams or higher. So pravastatin, simvastatin are not even achieving that greater than 50% reduction in LDL. So I tried to look into this evidence for LDL targets. I mean, there are no direct randomized trials comparing LDL goals. We do have some data from a cholesterol treatment trialist meta-analysis that shows that an LDL target of less than 70 provides perhaps the best benefit in terms of cardiovascular disease reduction. But the question is, should we be going lower, and is lower better? So this was, you're probably familiar with the Jupiter trial, but this was a large trial, over 17,000 apparently healthy men and women who had a high sensitivity CRP greater than 2, who were randomized to rosuvastatin versus placebo. And overall, you can see in the trial that major adverse cardiovascular events were reduced by 44% in patients who were randomized to rosuvastatin. But the magnitude of the benefit was directly related to LDL level. So if you look at participants who achieved an LDL of less than 50, they had a 65% reduction in major adverse cardiovascular events. So they did a lot better if their LDL was lower, and that was without an increase in adverse events. So despite this and all this data, this is another study that looked at over 900,000 Medicare patients and looking at statin use in different vascular conditions. And you can see that in the patients with PAD only, so who do not have concomitant coronary heart disease or cerebrovascular disease, these patients, only 33 or 34% of them are being prescribed any statin at all, and only 15.6% being prescribed high intensity statin, which is what would be considered the appropriate dose for a patient with PAD. Then when you include patients who have coronary heart disease along with PAD, you see that they're, again, not great, but a lot better in terms of getting them on a statin or appropriate statin compared to patients with PAD only. One of the barriers, I think, to statin use, particularly in PAD patients, is intermittent claudication. I think a lot of PAD patients are concerned about taking a statin or increasing the dose because they associated with side effects of myalgias, which are very similar to their claudication symptoms. And in fact, we have this problem where a lot of our PAD patients stop their statin because they think it's causing their claudication. So that may be one of the barriers in this patient population. So now I want to talk a little bit about the PCSK9 inhibitors and the FOURIER trial. So the FOURIER trial was a large randomized trial looking at evolocumab versus placebo in over 27,000 patients with atherosclerotic disease. Those patients were all on statins, but had not achieved an LDL goal of less than 70. The trial included over 3,600 patients with PAD, and the primary outcome was a composite of cardiovascular death, MI, stroke, and coronary outcomes. And then there was also secondary outcome looking at major adverse limb events. So this is the result from FOURIER in PAD patients. So patients with PAD had an impressive 59% reduction in their LDL with evolocumab compared to placebo. And that resulted in this 3.5% absolute risk reduction in the primary endpoint in patients treated with evolocumab with a number needed to treat of 29. And this is versus 1.4% absolute risk reduction in other patients in the trial, CAD or stroke patients who did not have PAD. I'll also note that this study also confirmed what we already knew, that PAD patients in general are at much higher risk for cardiovascular events relative to patients with CAD or stroke, but who don't have PAD. Similarly, the trial showed a 42% relative risk reduction in major adverse limb events in PAD patients treated with evolocumab versus placebo. And in the major adverse limb events, they showed that really the lower the LDL was, the lower the risk, almost a linear relationship all the way down to an LDL of 10, resulting in a lower risk of major adverse limb events. So these data obviously are compelling, and I certainly consider using PCSK9 inhibitors in my high-risk PAD patients who haven't achieved their LDL target on statin. But it does depend on their insurance plan and how much they're covering. And it is still very expensive and unclear if it's cost-effective at current prices, but hopefully that will change. So I'd like to talk a little bit about hypertension. I'm not going to spend a lot of time on hypertension because we essentially treat according to current guidelines. But I wanted to make 2 points, which is that number one, beta blockers are not contraindicated in PAD. They do not worsen claudication as was previously thought. And then the second point I wanted to make is to consider treating these patients with ACE inhibitors or angiotensin receptor blockers. And that's mainly coming from data from the HOPE trial. And this trial was also a large trial, over 9,000 high-risk patients randomized to ramipril versus placebo. And you could see that ramipril significantly reduced the risk of stroke, MI, or vascular death in these patients. And this was actually independent of their blood pressure reduction. And then the benefit from the treatment with ramipril was also noted. It was also preserved in the PAD subgroup. So I think we can say that ACE inhibitors and angiotensin receptor blockers do reduce the risk of cardiovascular events in patients with PAD. And so they would be a good choice for treatment of their hypertension. And you could even argue to start them on it, even if they don't have hypertension at baseline. So now I'd like to shift gears and talk a little bit about antithrombotic therapy. I'm going to preface this by saying this is a huge topic right now, and there's a lot of data that's come out in the past couple of years regarding this. So I'm going to do my best to summarize it in the time I have, and hopefully won't go too fast through some of it. But so this is a clinical decision-making algorithm that was published in JACC a couple of years ago to help clinicians deal with antithrombotic therapy in PAD patients. And this, this looks like a very busy algorithm, but essentially it makes a distinction that whether we're talking about a symptomatic PAD patient, so someone with claudication, versus someone who has undergone revascularization, those are treated very differently. So I'll talk a little bit about just the symptomatic PAD patient, the one with claudication. So the data for antiplatelet therapy in this patient population was mainly derived from a meta-analysis that was published in 2002 and included over 9,000 patients with PAD, and overall showed a 22% reduction in risk of the primary outcome, MI, stroke, and cardiovascular death in patients with PAD. And benefit was actually consistent across all PAD subgroups, including the ones who had undergone revascularization. And the main antiplatelet agent used in this trial was aspirin. Now, the CAPRIE study was a large cardiology trial. Actually, it was a randomized trial of over 19,000 patients who had had recent stroke, MI, or had symptomatic PAD. And that was, they were looking to assess the relative efficacy of clopidogrel versus aspirin in reducing the risk of a composite outcome, MI, ischemic stroke, or vascular death in these patients. So overall cohort results, clopidogrel was superior to aspirin in preventing the primary outcome, but the relative risk reduction of 8.7% was relatively small and really of marginal statistical significance. This is in the overall cohort. But if you look at the subgroup analysis in CAPRIE, you can see that the PAD patients had this 23.8% relative risk reduction in cardiovascular events if they were treated with clopidogrel over aspirin. So it is on the basis of this subgroup analysis from the CAPRIE study that the FDA approved clopidogrel for the treatment of patients with PAD. We do recommend antiplatelet therapy to reduce cardiovascular events in these patients, but really the recommendation is for either aspirin or clopidogrel alone based on these data. So dual antiplatelet therapy is not indicated really in any of PAD patients who have not undergone recent revascularization. And in fact, like in the Charisma trial, there was only an increased risk of bleeding for patients treated with dual antiplatelet therapy. These studies also kind of pointed to another conclusion regarding the antithrombotic limitations of antiplatelet therapy. For example, ticagrelor is actually a more potent antiplatelet than Plavix, but when it was studied in the Euclid trial, there was really no benefit over clopidogrel in terms of lowering event rate in PAD patients. So this suggests that maybe there are other thrombotic mechanisms at play in these patients. And this sort of opened the door to exploring or investigating the direct oral anticoagulants in PAD patients to reduce their cardiovascular risk. So this is what the COMPASS trial was about. This was published in New England Journal in 2017. Included over 27,000 patients who had stable atherosclerotic disease and randomized to low-dose rivaroxaban, 2.5 BID plus aspirin, versus rivaroxaban at a higher dose or aspirin alone. And the primary endpoint for COMPASS was composite of cardiovascular death, MI, or stroke. So this is the overall result in COMPASS, and you can see that patients who were treated with rivaroxaban plus aspirin had a lower risk of the primary outcome, cardiovascular death, MI, and stroke, compared to rivaroxaban alone and aspirin alone. There was an increase in major bleeding in the patients with who were taking rivaroxaban plus aspirin. Most major bleeding was into the GI tract, and notably, there was no difference in intracranial or fatal bleeding or bleeding into critical organ. So what they did is they did this analysis where they looked at bleeding events and this sort of net clinical benefit outcome. And what they found was that you have an absolute risk reduction of 1.2% in patients treated with rivaroxaban plus aspirin versus aspirin alone. Now, the COMPASS PAD trial was also based on this rationale that PAD patients are at very high risk for both adverse cardiovascular and adverse limb outcomes. And actually, few therapies that we have clearly reduced both cardiovascular events and major adverse limb events. So this was something they really wanted to look at in COMPASS. So PAD patients included in the trial had to either have had prior revascularization or have intermittent claudication with documented low ABI. Interestingly, they also included some patients with carotid disease under the PAD arm of the study. And the key efficacy outcomes were, again, major adverse cardiovascular events and major adverse limb events. So you can see here, this is in the PAD patients who were treated with rivaroxaban, low-dose rivaroxaban plus aspirin, had a 28% lower risk of cardiovascular death, MI, and stroke compared to aspirin alone. And similarly, 46% lower risk of major adverse limb events with rivaroxaban plus aspirin versus aspirin alone. So again, they did this net clinical benefit analysis in the PAD population and found this absolute risk reduction of 2.5% in rivaroxaban plus aspirin versus aspirin alone. So, obviously, COMPASS trial was an important step forward in these the treatment of these patients, and it's certainly likely to change practice guidelines. Although I haven't seen really a comprehensive guideline update incorporating COMPASS into that PAD. So there's some, people had raised some concerns about the early termination of the trial, perhaps overestimating the degree of benefit. But the other point I want to make is that the increased major bleeding, even though there was no increase in intracranial or fatal bleeding, still major bleeding can be a problem. And I would think that should lead us to carefully consider treatment more on a case-by-case basis as opposed to a broad application in patients with PAD. So what you're looking at is someone who has a high thrombotic risk, which would outweigh their bleeding risk. So this was just something that trial that where they looked at how adherence to guideline recommended therapy after revascularization affected outcomes. And basically, This was actually before COMPASS, so they were just looking at aspirin, statin, ACE inhibitor use, and smoking cessation. And what they found was that in patients who were receiving all four therapies, there was a 44% reduction in all-cause mortality, as well as a significant reduction in major adverse cardiovascular events and major adverse limb events. So those therapies work. The question is, how well are we using them? And this is data from NHANES that shows you that we're actually not using them well at all, certainly not in patients with PAD. So this is looking at patients with PAD who do not have documented cardiovascular disease. And you can see here that only 18.7% of them were prescribed any statin. Only 21% prescribed ACE inhibitors and 27% prescribed antiplatelets. If they had PAD, but also had a diagnosis of cardiovascular disease, then these numbers improved, although still not great. You had much better statin use and antiplatelet use in those patients. So that really tells me that these PAD patients here are not being adequately treated, and probably because they're not being recognized. The Partners program actually looked at this. They went and evaluated close to 7,000 patients who were enrolled in primary care practices across the US. And they were just looking at high-risk patients. So they looked at age greater than 70 or younger patients with smoking or diabetes. And they did ABIs, screening ABIs on all those patients. And they found a prevalence of 29% of PAD in these patients. And notably, 55% of the patients were newly diagnosed. Despite being enrolled in primary care regularly, they had not been diagnosed with PAD until this screening ABI program. In addition, patients who had a known diagnosis of PAD prior to the program, 83% of those patients were aware that they carried their diagnosis, but only 49% of their primary care physicians were even aware that the patient had PAD. So that's obviously going to impact on the treatment of these patients. So, people have been asking, how can we do better? I think it really starts with PAD screening and recognizing these patients to begin with. So our Society for Vascular Medicine, as well as ACC/AHA, recommend ABI screening in at-risk patients. These are those patients who are above the age of 65 or 50 to 65 with diabetes or smoking. The problem with this is there are reimbursement barriers. ABI testing as a screening test is not reimbursed by insurance or by CMS. So you can see why physicians might be reluctant to be doing these screening ABIs in their offices. It takes some time and some resources, and then they're not getting reimbursed for it. The other things is the symptoms that go underreported. As I mentioned before, patients have very atypical leg symptoms, which they often attribute to aging or their arthritis or their neuropathy. So they don't bring it up to their physician. And conversely, the physicians don't routinely ask patients about their leg symptoms either. So one thing we could do in a sort of a primary care setting is to have some sort of screening questionnaire when the patients come in, and really ask them in detail about leg symptoms, any fatigue, weakness in the extremities with exertion, any prior PAD procedures in their history, and certainly at-risk patients who have any lower extremity symptoms, even if they're atypical, should really have ABIs performed to look for PAD. So I'd like to move on to the last part, which is to talk about improving the functional status and limb preservation in these patients. So exercise is a big component of what we do to treat these patients. We have multiple studies. This is a meta-analysis of over 21 studies of claudication patients who underwent exercise training. And we showed that you can really improve pain-free and maximal walking times in these patients. Up to 180% pain-free walking time and 120% maximal walking time with exercise training versus control. The exercise therapy is actually quite specific. It should be at least 3 sessions a week supervised. And you're using a treadmill preferably or track. And with the idea of reproducing the claudication and having patients walk through it and then stop and restart exercising again. Ideally, the duration should be 6 months or more of exercise training. It is very effective form of treatment. It's also not very expensive. and is recommended as first line by all major vascular societies. It is finally now covered by CMS for symptomatic PAD patients. This was a decision that was made not that long ago in 2017. So it is available and usually available through cardiac rehab centers for patients with PAD. Pharmacologic options are pretty limited in terms of treatment of claudication. We no longer use pentoxifylline. It has been shown not to perform any better than placebo in more recent trials. So silostazol is the agent we have available. It was approved by the FDA in 1999, and it's actually been well studied in 5 randomized trials and shown to improve walking distance compared with placebo in patients with PAD. It's a BID dosing medication, and there is, because it's a phosphodiesterase type 3 inhibitor, it is a black box. There is a black box warning for CHF patients. So unfortunately, we can't use it in patients who have CHF. So this is just showing you the studies that were done on using silostazol and showed the benefit versus placebo. So when do we send these patients for invasive treatment? I think for when we're talking about claudication, not necessarily limb preservation, which is a separate issue, but if you have someone who just has claudication, I think what you want to look for is that they have lifestyle disabling symptoms that have not responded to more conservative measures like exercise therapy and silostazol. And you want to give these measures at least 3 months before making a decision about intervention. You also want to make sure that there's a good likelihood the patient will get better after the intervention. And then we also look at risk-benefit ratios in terms of location of disease. If it's aortoiliac versus SFA disease, that can change that risk-benefit ratio. The truth is that peripheral intervention, which is very useful for patients who have non-healing ulcers or for limb preservation, is still a problem in terms of restenosis. And that's really the main reason why we try to delay endovascular intervention in claudicants, because of this issue of restenosis in the peripheral arteries. Surgical bypass has a better patency rates than stents, but a much higher operative mortality, perioperative mortality rate, and then risk of complications like wound infection. So I think it really is used sort of as a last recourse in treating claudicants for their symptoms. So going back to our patient, the 54-year-old with PAD, I think there's a lot of things you can do to reduce his cardiovascular risk. We would start this patient on an aspirin, 81 milligrams daily. I would change his simvastatin over to either atorvastatin or rosuvastatin, higher intensity. Add an ACE or ARB to his blood pressure regimen, and obviously work on smoking cessation. We would refer him for an exercise program and prescribe silostazol at the same time to see if we can improve his functional status. And then if he comes back after a few months and says that he's still having persistent lifestyle disabling symptoms despite that conservative treatment, then we would consider sending him for revascularization. So now I just wanted to give you a bit of a different case to talk about what we do post-revascularization. So this was a 58-year-old gentleman who had had an SFA stent previously and presented with complications, SFA stent occlusion in 2016 that required atherectomy and angioplasty. His risk factors included current tobacco use, and he also had known CAD and prior MI. So about 6 months after the second intervention on his stent, he presented for an urgent visit with symptoms of acute pain and numbness in the left leg and foot. He actually limped into the clinic, and on exam, he was found to have a pale left leg and foot and non-palpable pulses. This was his ABI testing, which basically showed non-dopplerable pulses in the left leg and no flow with the PVR tracing. So this is a presentation consistent with acute limb ischemia. And you can see here on his duplex that he had a thrombotic occlusion of his SFA stent. So he was referred to vascular surgery emergently and thankfully did well after a FEMPOP bypass without significant complications. But the question for this patient is, could we have prevented this major adverse limb event? And can we prevent future events, both vascular events and limb loss in the future? So after revascularization, there's a lot of uncertainty in PAD patients. of what kind of treatment we should give them. Dual antiplatelet therapy is used in CAD patients, but we don't have a lot of data regarding PAD patients, and certainly no recommendation regarding duration and intensity. We know that after revascularization, patients with PAD are at increased risk for both major adverse limb events and cardiovascular events over time. And you can see here actually that after revascularization in these Kaplan-Meier curves, limb events increase pretty quickly and then sort of plateau out at 1 year, but cardiovascular events continue to go up. And notably, the risk for both limb events and cardiovascular events continue to remain elevated for years after revascularization. The surgeons have looked at this extensively, looking at dual antiplatelet therapy in patients with bypass grafts and also warfarin to help prevent graft occlusions or need for revascularization. And none of these therapies have proven really useful, and warfarin especially an unacceptable increased risk of bleeding in those patients. So that's sort of the background for the VOYAGER PAD trial. This was a large trial looking at patients who had PAD patients who had undergone recent revascularization and looking at a primary composite outcome of major adverse limb events and major cardiovascular events. And what you can see here is that if you look at the patients who were, I'm sorry, I forgot to mention the trial was a randomization of patients to low dose rivaroxaban plus aspirin versus aspirin plus placebo. And that was looking at prevention in this primary outcome. Sorry about that. So anyway, you can see that the patients who were randomized to the rivaroxaban plus low dose rivaroxaban plus aspirin group had a lower rate of composite outcome compared to placebo, with an absolute risk reduction of 2.6% at 3 years and a number needed to treat of 39. The other thing to note is that overall, this is really a dramatic first event rate in this trial. When you look at the cardiology trials in that context, you're looking at event rates of about 10% at 3 years in those trials. And here you have 1 in 5 patients having an event at 3 years. So these are very high risk patients. There was a bleeding risk here, and I'm gonna speed up a little bit in the interest of time, but essentially there was a 40% excess in major bleeding, notably no difference in intracranial or fatal bleeding. But you're looking really at a 6-to-1 benefit to risk ratio in terms of events prevented versus events caused. And it's important to note that this ratio actually changes over time. And the bleeding stress that occurs fairly early on. So once the patients, most of the patients who don't bleed actually tolerate the low dose rivaroxaban very well. But you can also see that the events prevented actually accrue over time. So there is certainly a benefit in these patients treated with a low dose rivaroxaban plus aspirin. So just to kind of conclude, these are the therapies that we have available for PAD. As of today, we have therapies for preventing cardiovascular events and for reducing limb events. And notably, I think the more recent rivaroxaban, low-dose rivaroxaban plus aspirin, and especially in patients post-revascularization, reducing their adverse limb events and cardiovascular events as well. And then also statins and PCSK9 inhibitors having the benefit of preventing cardiovascular events and major adverse limb events. We also obviously use behavior, smoking, and exercise, as well as silostazole to help with like symptoms. So this is sort of my PAD prescription. If I have a patient like the patient I presented early on, I will have them on a single antiplatelet agent, either aspirin or clopidogrel, but I will consider adding low-dose rivaroxaban in select patients. Those would be the patients that I consider at high thrombotic risk, who may have also a low bleeding risk. And especially post-revascularization, in somebody like the second case that I presented, who have had recurrent limb events, recurrent stent occlusions, requiring revascularization and surgical therapy, you may consider also adding low-dose rivaroxaban in those patients. The other thing, obviously, is we use statin, high-intensity statin, to achieve an LDL of less than 70 and consider adding the PCSK9 if needed if you have not achieved the target LDL. I preferentially use ACE inhibitors or ARB to control blood pressure in these patients. Tobacco cessation, obviously I talked about, we spend a lot of time on that. Refer them for exercise therapy. If they don't have CHF, prescribe silostazole, and then refer them for intervention if all else fails. Or obviously if there's an evidence of limb threat, those patients get referred to surgical endovascular colleagues. Thank you very much.